Thank you, Garish and Luis. I want to thank the WGO and the course program directors for inviting me here today to discuss the natural history of pancreatic cysts. For today's lecture, I'm going to focus on some background information on pancreatic cysts and discuss why it's really important to try to differentiate between the different types of cysts, because that in turn is going to give us information on what their natural history will be and what their risk for malignancy is going to be. But first, I wanted to start out with a recent case that was referred to my EUS practice. And I think it's also important because it highlights a few key features when you're dealing with pancreatic cysts. This is a 62-year-old male who presented with epigastric pain for a few days, found to have a mildly elevated lipase level. He never had pancreatitis in the past, and on admission abdominal CT scan, he had this very nice, well-circumscribed 5-centimeter pancreatic cyst. Now, he was told that he had acute pancreatitis, and this is a pseudocyst, and you should go and get this drained. Now, I'd like to argue that that diagnosis is incorrect, and there were a couple clues in the history and the imaging that should kind of give you an idea that you should be thinking about something else. Although pancreatic pseudocysts are the most common cysts we see, you need to have a documented episode of prior pancreatitis because you need that episode to develop acute fluid collections, and then over the next 6 to 8 weeks, the majority are going to resolve, but a few are going to become organized into a well-rounded pseudocyst. But in this particular case, the patient never had pancreatitis, and he showed up with a well-rounded cyst on day 1, which would not be a pseudocyst. So although it's much less common, you definitely need to think about pancreatic cystic neoplasms. So why do we care about pancreatic cysts? Well, the issue is that we're finding them more and more. Almost every patient that goes to the ER, whether they have abdominal pain, arm pain, a headache, they're going to get a CAT scan or an MRI almost always before they leave. And some population studies have shown that in the US, there's about a 2.5% prevalence of pancreatic cysts. So if you figure there's 320 million people in the US, that's over 8 million pancreatic cysts that we're going to find. But less than 5% of those, or the minority of cysts, are ever going to turn into cancer. So our job is trying to distinguish which of those few cysts are going to have malignant potential. In terms of the most common cystic lesions you're going to find, I already mentioned that pseudocysts are by far the most common, but once you get into the cystic neoplasms, the most common and the ones that you'll most frequently encounter are IPMN lesions. Most commonly they occur in the head. In the body and tail, you have mucinous cystic neoplasms, or MCNs, and then serous cyst adenomas have an even distribution throughout the pancreas. And when I think about pancreatic cysts, I think the easiest way to differentiate them is just to divide them into 2 basic categories. The ones with malignant potential that we call mucinous cysts that include IPMN and MCN lesions. And those are the ones that we're going to have to do ongoing surveillance and possibly refer for resection. And this is as opposed to the benign or non-mucinous category, which includes pseudocyst and serous cyst adenomas. And those are ones that perhaps you don't need to monitor at all. And it helps you inform the patient about what to expect from their cyst. In terms of making the diagnosis, I think this is, again, in medicine, probably the most important step is always to look at your patient and get a really good history. You can already start making the differential based on how old your patient is, what their gender is, did they have a history of pancreatitis, are they symptomatic from the pancreatic cyst. And then you can also look at cyst factors, and you can use imaging tools such as CT, MRI, and endoscopic ultrasound to help guide your imaging. In terms of cross-sectional imaging, CT and MRI are pretty similar in terms of predicting correct pancreatic cyst histology. I prefer getting MRIs with MRCPs to look at pancreatic cysts because you have less radiation exposure for patients, and you can also get pancreatic ductal anatomy to see if there's any communication between the duct and the cyst. And then obviously some of us, actually most on the panel, perform endoscopic ultrasound. My friend Dr. Linda Lee is going to go into more detail about the role of EUS with pancreatic cysts. But just briefly, some of the advantages of EUS are that you can pick up multifocal disease that may have not been noticed on CT or MRI. You can define septations. You can determine if a patient has chronic pancreatitis, and you can pick up worrisome features. But probably most importantly, you can sample the lesion. In terms of the different types of cysts and their malignant potential, again, serous cyst adenomas are probably more commonly found in women, a little bit older age group. They can be found throughout the pancreas, and oftentimes on CT you'll see what's called a central scar, or on EUS kind of a honeycomb or microcystic pattern that would be diagnostic even without a biopsy for serous cyst adenoma. There is some confusion when you're dealing with macrocystic variants where it can be confused with other cysts. Dr. Lee will talk more about cyst fluid analysis, but oftentimes these aren't that helpful. But if you can diagnose this correctly, they have low or no potential for malignancy, so the majority of cases you're just going to observe. You would only recommend surgery if the patient was symptomatic or if the diagnosis was in question. And this is just a brief video showing you an EUS of the microcystic kind of honeycomb lesion. For mucinous cystic neoplasms, this is almost always going to be a female in a little younger age group in her 40s. Typically, the patients are asymptomatic and they have cysts located in the body and tail of the pancreas. Oftentimes, you'll find septations, and again, although cytology and cyst fluid analysis may not be that commonly diagnostic, perhaps you'll see ovarian type stroma. Now these definitely have, in some reports, up to a 36% chance of having cancer. So if you can make the diagnosis, you would recommend surgery for these patients. Now, IPMN lesions, again, these are the ones that you're going to most commonly see. A lot of times and a lot of studies have shown that you can prognosticate which lesions have a higher risk for malignancy based on what their staging is in terms of dysplasia, which often you don't know until after surgery, but you can tell a little bit in terms of their malignant potential, whether they involve the main duct or the side branch ducts, and also if you can figure out the histologic subtype. So in terms of which part of the duct the cysts involve, main duct IPMNs, as the name implies, involve the main pancreatic duct, which often is very dilated, as opposed to lesions that involve the side branch ducts. And there have been multiple studies that have demonstrated cystic lesions that involve the main duct are at much higher risk for progressing to malignancy than side branch cysts. And this particular study looked at almost 300 patients. It was a Japanese retrospective study in 300 patients that did not undergo surgery, and they had interval surveillance with cross-sectional imaging over many years. And they found that main duct IPMNs had a 5-year progression to pancreatic cancer in 46% of cases, as opposed to the lower 4% progression to cancer in the branch duct lesions. So definitely main duct lesions have higher risk for malignancy. Also, people have looked at getting histologic subtypes of IPMNs, and they think that second only to the staging aspect, histologic subtypes may be the second most important predictor of survival in terms of IPMN lesions. The most common type is the intestinal type, but you also have gastric, pancreatic, biliary, and oncocytic types. Now the problem is there's a lot of variability within a cyst wall in an IPMN, so you may not be able to get an accurate histologic subtype just from your cytology with EUS-FNA. So oftentimes you won't be able to necessarily risk stratify until or after the patient goes to surgery. Again, this was another retrospective Japanese study in 300 patients that did go to surgery, and they showed that the histologic type of IPMN was an independent predictor of survival. And the pancreatic biliary type had the lowest survival out of all the types. So how do we go from a pre-malignant lesion, such as an IPMN lesion, to pancreatic cancer? Well, it appears that there's various alterations in signaling pathways that affect not only the tumor epithelial cell, but also affect the surrounding stroma. And this has led some people to propose that in patients who have pancreatic cysts, not only can you develop cancer within the cyst, but perhaps there's a field defect that would put the patient at risk for developing cancer in general, and not even within the actual cystic lesion. And this is also illustrated in this study where they looked at 50 patients and took peripheral blood samples, and they found that in a third of the patients who had cystic lesions but no obvious cancer, they already had circulating tumor cells in their blood samples, indicating that perhaps this is a precursor to the development of cancer. Obviously, further studies would be needed to see if this was something that we could use to risk stratify patients with cysts. So in terms of, again, malignant potential and natural history, main duct IPMNs are going to be the minority of IPMN lesions that you see. Most patients are going to be symptomatic, and the telltale signs are on cross-sectional imaging. You see a very dilated pancreatic duct, and often on endoscopy, you see a gaping or fish mouth ampulla that's extruding mucin. And then again, I want to reiterate, these have a very high likelihood of either harboring malignancy at the time of diagnosis or progressing to cancer. So therefore, we would recommend surgery for all main duct IPMNs. And this is a video showing a cystic lesion, and you can see there's a solid mass component to it. There's a very dilated pancreatic duct. Normal pancreatic duct is 3 millimeters. And you target the solid area with your needle, and here you can see gaping ampulla extruding mucin. So this by itself would be diagnostic of a main duct IPMN. Now, side branch ducts are mainly found in asymptomatic patients. They account for the majority of IPMN lesions. They can be solitary or multifocal, and in these cases you have a normal caliber pancreatic duct, and again, if you have multiple cysts, that's often enough to give you the diagnosis. These, we think, have a little bit different biology than main duct IPMNs. They're slower growing, and based on limited surgical studies, their annual incidence of cancer may be around 2%. So we recommend surgery in a select group of them. Again, Dr. Lee is going to go into more detail, but there's been multiple studies where they try to look at predictors of malignancy, and some of the things they looked at were size greater than 3 centimeters and the presence of a mural nodule. And these are things that we look for in EUS. But having said all this, this study out of Mayo Clinic shows that despite the increasing incidence of IPMN lesions being found, we really haven't altered the incidence of IPMN-related cancers. So it seems like this rising incidence of IPMN is more a disease of technology, and we're not really picking up necessarily clinically significant lesions. So I think this is something you need to think about, especially when you're discussing pancreatic cysts with the patients who have them, because they have obviously a lot of anxiety related to the lesions, but I think you can try to reassure them that the minority are going to progress to cancer. So in conclusion, nowadays we're using cross-sectional imaging more and more, so we're finding pancreatic cysts on an increasingly rising basis. I think it is important, though, to try to subclassify the type of cysts using imaging modalities such as CT, MRI, and EUS, because although the vast majority of these cysts are benign, we do want to try to identify those few that have malignant potential, because that's going to affect their subsequent management. And obviously, this management has to be done in a multidisciplinary fashion, and you should include your surgeons, radiologists, and oncologists when needed. Thank you.